Vitamin D and calcium, two nutrients we all need to maintain our health and live healthy lifestyles. But there's a problem. Over the past 10 years, we've been bombarded with mixed messages, conflicting reports, and all sorts of claims related to these two nutrients, especially when it comes to vitamin D. So, to clarify just how much vitamin D and calcium we all need, the US and Canadian governments asked the Institute of Medicine to come up with some numbers, using higher quality studies and better information than were available back in 1997. That's when the dietary values for these nutrients were first set. And after all these studies, they came up with this exhaustive and comprehensive report on vitamin D and calcium. So let's take a closer look at these new dietary guidelines with our panel of experts, starting with Dr. Stephen Clinton from The Ohio State University, Dr. Patsy Brannon from Cornell, Dr. Greg Plotnikoff of the Alina Center for Healthcare Innovation, Dr. Connie Weaver from Purdue University, and Dr. Pete Huth, who serves as a consultant on behalf of the Dairy Research Institute. First of all, what is the difficulty with assessing acceptable levels of serum 25D for good bone health?
Well, one challenge that we encountered in the nature of the evidence is that frequently studies were done giving both calcium and vitamin D, and that makes it difficult to determine the independent effect of either. So when you start looking at dose response in order to set the dietary reference intakes, that's a challenge doing the dose response. Another challenge is that by their very nature and expense, randomized clinical trials frequently only test one dose. So randomized clinical trials are very good for telling us if there's causal effect. They may by themselves not be fully helpful in assessing dose response. And there, the committee found useful observational studies that helped us discern the dose response effects. So it is a challenge, and it involves scientific judgment. And that's one of the charges to us in the report, was to be clear about what the limits of the evidence were, where the gaps were, and how we were making our decisions based on our judgment.
So we need more research and studies into serum 25D and its role in maintaining our health?
Absolutely, and one of the charges to the readers of the report is to take very seriously the importance of serum measurements, I believe. And this is because one size does not fit all. And we know that although the report addressed many issues that we just covered, it didn't address the variation by the obesity epidemic in the United States. And that maybe someone who's quite large needs more of a dose than someone who's quite thin. That becomes a variation. And the one-size-fits-all intervention doesn't account for the fact that people start with all kinds of different levels to begin with. A pharmaceutical study, if we study, say, a new calcium channel blocker, everyone starts at serum level 0. And so dose becomes very important. And you can measure dose effect and dose response curves, pharmacokinetics. But when for a nutrient, everyone starts all over the map. And the idea is you don't want to focus on dose, you want to focus on what serum level is necessary for a given population to achieve certain desired outcomes.
And this is precisely why the committee had to link the bone health outcomes with serum vitamin D levels, because the limitations in the evidence don't allow us just to look at vitamin D intake per se. And so we looked very carefully at the outcomes related to skeletal health, and we linked a serum 25-hydroxy-D level of 50 nanomoles per liter, or 20 nanograms per ml, with skeletal health. And so below that level, and that 15 nanomoles per liter meets the needs of 97.5% of the population. And so that allows us then to link that bone health outcome with the serum 25-hydroxy-D. And that was very helpful then in looking at how much vitamin D do you need to consume in order to achieve that level of serum 25-hydroxy-D.
And this is important because, yes, achieving that level is very important for bone health. And just the direct cost of osteoporosis alone in our country is $17 billion a year. So that is an incredibly important public health advancement that this committee put forth. What is not known is, well, for cancer, cardiovascular disease, autoimmune disease, and a long list of things, which are also very important public health issues, what is the serum level necessary for good outcomes for those? And that is a huge research area.
I would really agree with that. Not only do we need dose response, but we need to know, is there actually causal effect?
Yes.
And that, I think, still remains to be determined. And that's where the randomized clinical trials are going to be very important for us for these non-skeletal health outcomes.
So let me add a little bit of an opinion about the serum vitamin D. From a public health point of view, the majority of North Americans are not going to be vitamin D deficient with the intake that we currently have and our sun exposure. And this committee report would not recommend that vitamin D be part of the workup of a healthy clinical visit every year. On the other hand, the medical model says that if someone is seeing a physician with an illness or a symptom that could be related to one of the disease processes that are related to vitamin D, that is when it is appropriate to be checking for vitamin D levels and then treating each person individually and personally and subsequently monitoring their vitamin D status with the serum testing. So I think this is not something that we should be recommending for all healthy individuals to check routinely, just like we wouldn't be doing that for other disease screening tools that we use for specific outcomes that are designed for those at risk or in certain age groups.
So if I want to counsel from an evidence-based perspective, the evidence I need now when working with someone is, okay, if we measure and they're low, and we replenish to some given level, does that make a clinical difference? And there's a huge missing research component in that regard. And so it's limited. So I move away from counseling from an evidence-based perspective to an area where I could introduce bias and opinion. And that's why I like measurement, because it helps guide my thinking process. I have an external validation or invalidation, so it keeps me clean, so to speak, in that regard.
Perhaps what we have now when it comes to this is more of an anecdotal perspective.
Yes, so for example, I shared earlier with the group, I do a lot of work with chronic pain. I can tell you, it's so easy to measure, replenish, and see someone improve from chronic pain or chronic weakness.
Based solely on replenishing their vitamin D levels.
And N of 1 clinical trial. I don't have to wait 8 years for NIH to publish something. I don't have to go through 3 rounds of an R01 application to try to get something. No, I can know within a month how someone is doing. And week after week after week, if you see people who come in with profound suffering, and you simply measure vitamin D and simply give them some vitamin D, and it resolves, it's kind of like, well, what more do I need? Okay, but the point is, what more do I need as a clinician is very different than what do we as a society need for a public health recommendation. And that's where the kind of struggle around the report has come, is that it's very important we have both. Both are necessary, neither alone is sufficient. Because the mandate for this committee was to be cautious, because these are long-lasting recommendations. They're going to be around for 20 years or so. But looking at those U-shaped data in African Americans, because so few African Americans have high levels, is a very different population than the majority population of African Americans. And the confidence intervals were just so much broader than at any other level. So there's more nuance to the data, and it really drives us to again say we really need more serum levels, and we really need more data to guide this. I think we need to look at gene expression. I think we're going to, because that's going to be one way of looking at toxicity, perhaps. And we need to look at seasonal variation. And in fact, what you're hearing is that there's many lifetimes worth of research that needs to be done here.
Okay, we want to remind everybody that we are talking about vitamin D and calcium. We can't talk about vitamin D without talking about calcium. They are complementary nutrients after all. So let's talk about both of these in concert. What is the relationship between calcium intake and absorption and vitamin D?
So calcium is absorbed by two pathways, one that requires vitamin D and one that doesn't. You need quite a bit of calcium to only use the pathway that doesn't require vitamin D, and that's beyond what most people take. So in order to best utilize calcium, you need an adequate supply of vitamin D, and that's only for calcium absorption, which we know the most about. So they're very intimately linked because calcium is a major constituent of bone. You need to have it absorbed from the diet and transferred to the bone. And you can't make calcium like you can vitamin D. There are many other differences between calcium and vitamin D. You don't have a serum measure you can check calcium status. So you have to rely only on diet for calcium, and you can't monitor your progress except for years later in terms of bone health.
Right, you can't get calcium from the sun.
That's right.
So let's talk about the patient-doctor relationship, as I'm sure a lot of people are wondering about. Is it possible that your doctor is overdiagnosing when it comes to vitamin D deficiency?
Well, I'll start, and I'm sure others would like to comment. And I would say it's not just possible, it's very clear that it's happening. And I think that what we have seen is that as some of these very provocative but inconclusive studies have come out in recent years, emphasizing the potential role of vitamin D in many health outcomes, we have seen the access to vitamin D assays greatly increase. In part, I think this is simply because marketing has been part of that. And we are seeing physicians who really don't understand nutrition and vitamin D begin to order these tests as almost routine part of their medical evaluation. And unfortunately, there also is a lack of consensus about what level of vitamin D is considered the normal range. And so many of the vitamin D assays are being reported back to physicians with a label that a certain number is deficient, when indeed much of the work that we did on the DRI committee would suggest that blood levels between 20 and 30 would indeed be adequate for bone health. And so we've got a very complex dynamic underway there. I think we have some misinformation and a lack of fundamental nutrition knowledge in the medical community. We're seeing some, shall we say, hype in the popular press and media, and we're seeing a lack of, say, a national organization taking responsibility for defining what should be an acceptable normal range.
Let me add to that a little bit. From my practice, I mostly see people who have been underdiagnosed or have failed to be diagnosed with vitamin D deficiency despite severe symptoms and despite multiple pharmaceuticals that they're on and long workups. So that's one thing. So we may be overdiagnosing in the healthy population, but in the unhealthy population, it's clearly being undiagnosed. Additionally, low vitamin D is really important in a number of conditions. For example, in breast cancer, vitamin D levels greater than 40 allow women to stay on life-saving aromatase inhibitor therapies, which cause arthralgias. Several clinical trials have suggested that. Clinical experience, from my perspective, is yes, absolutely, that's important. Statin myalgias, people in cardiovascular disease who develop muscle aches and pains while on another life-saving medication, or at least preventative medication, you normalize their vitamin D levels, it goes away. So this goes on and on. We look at pain status and functional status in lupus and other diseases, and I say, good grief, when someone has a serious disease, we should at least get 1 vitamin D level on them. We think nothing of getting cholesterol level. We get cholesterol levels 1, 2, 3 times a year sometimes in people. Think nothing of it. Think nothing of getting a B12 level. Think nothing of getting a calcium level or a sodium level or potassium level. But all of a sudden we start checking a vitamin D level and it arouses national concern. And yes, vitamin D levels have testing has gone up significantly. But I think we're going to see more and more studies showing that actually is going to end up saving money. And so that speculation, we'll see. It could be proven wrong.
We have to understand what the desired levels are, though, to interpret
Yes.
lab results.
But getting back to your question with regard to overprescribing vitamin D or even other nutrients, I think the mentality has been more is better. And in nutrition, it's very rare that a single nutrient will work in isolation. It's usually quite synergistic with many other nutrients. So, for example, in consuming, for example, foods that have multiple nutrients that are related to bone health, for example, calcium, vitamin D, magnesium, vitamin A, potassium, all work in concert together. And so from a prevention standpoint, one nutrient and overprescribing that one nutrient may defeat the purpose of a balanced diet in which these nutrients, for example, dairy products is a good example, where these multiple nutrients are in significant amounts and act in concert from an overall preventative, from a preventative mode for overall bone health. So I think that's from an overprescription standpoint, that concept I think needs to be sort of refocused.
So to his point, we did a study that we published a couple of years ago in an animal model study, and through growth, we gave the animals the recommended nutrient intakes for all the nutrients. We gave them the same amount of calcium, but one group got it as non-fat dry milk solids and the other got it as calcium carbonate. And the group that were fed the non-fat dry milk solids grew larger, denser, stronger bones. And even if they were put on a calcium deficient diet later in life, if they had been raised on the milk, they did better. They preserved some of the bone strength longer than if they had been raised on calcium carbonate. What is it about this complex food? It's not just one or two nutrients. It's all the constituents and bioactives and the concert of nutrients that we don't yet understand.
And at what age you received this.
Exactly.
As well. So, and I'd like to hear from each of you on this. I think a good way to wrap up would be to hear, based on this new study, based on these core recommendations, how would you like to see this nation, to see the field of medicine move forward?
Well, I'll just say a couple words, given that I'm on an editorial role here, and that is that, a healthcare system really needs to be focusing on preventive medicine as opposed to reactive medicine. And I think if we're going to see people live long and fulfilling, healthy lives, we need to kind of switch our approach to attempting to solve very serious problems too late in their course to prevention. And I think that's going to take a certain amount of research and resources, but it's also going to take major changes in the healthcare system where primary care and preventive medicine take a greater role, and making sure that everyone, regardless of their ethnicity or social economic status, has equal access.
Dr. Brennan?
I would hope that we would have more and well-designed randomized clinical trials that would help us know whether there is a causal role for vitamin D and all of these intriguing linkages with so many different chronic diseases. And I would hope that we would also have some fundamental basic science that would help us understand some some real key points about vitamin D metabolism. We all speak about the fact that tissues other than the kidney can make the active hormone, 1,25-dihydroxy-D, but it turns out we have no evidence of that in a living organism. Our evidence for that only comes from cells in vitro. And so we need that kind of evidence. There are a number of things that our report details where we need to understand the interrelationship with vitamin D and calcium in order to be able to do the kinds of effective dose responsings that'll be needed once we know more about the role of vitamin D in preventing chronic diseases.
I'm excited about the promise that genomic studies, proteomic studies, metabolomic studies can bring to vitamin D research, and I know that we're moving fast in this area. I'd love to see that happen. It has to be also paralleled by a focus on the values and attitudes we impart in teaching of skills and knowledge in our medical schools regarding nutrients. And that I'm very much looking forward to a future of partnering with between physicians, nurses, nutritionists, dietitians, really establishing much more of a team approach. And that we have good research teams, that is good questions being asked, that will then be able to support these people counseling from an evidence-based perspective.
Dr. Weaver, your thoughts on moving forward?
So as a nutritionist, I've spent my whole life concentrating on prevention instead of treatment after the tissue has already disintegrated. And I think it happens really early. For some of the chronic diseases, the beginning is in the womb, responding to the mother's diet, and certainly very early on. But our grant system is in 5-year blocks, and we usually attack the problem after the tissue's already damaged. Like the biggest predictor of a fracture is having had a previous fracture. Well, if you've already lived a lifestyle that puts your bones at risk for the first fracture, what do you really think you're going to do now to try to prevent future fractures? The bang for the buck is early on to prevent that first fracture. And so we need to focus better earlier in life, preventing the tissue from becoming disordered or abnormal.
Dr. Ruth, your thoughts?
I think I agree with whatever everyone has said here. I'm looking at it for, I guess, a little more broad picture from the standpoint of where I sit with regard to having worked in the food industry and other areas, that we've done due diligence to a number of essential nutrients to try to understand the dietary reference intakes. We've been talking about calcium and vitamin D, but there are substantially a number of other vitamins and minerals that we know quite a bit about. I would like to see studies that can document that consumption of those nutrients in a preventative food-based system actually reduces healthcare costs. And if you could document that in a way that is going to reformulate policy so that actually these recommendations are actually now at the level where there's some government incentive now for good diets and the availability of good food for all Americans.
Great. Well, we started our discussion talking about vitamin D, but I think we've covered a lot of broader topics, both relating to the individual, to the medical field, to society as a whole. So I'd like to thank our panel for joining us. And we hope this is an ongoing discussion.